Welcome to the LACNet's podcast. I'm your host, Lisa Yen. I'm the LACNet's Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Thank you for joining us for today's episode of the LACNet's podcast. I'm excited to introduce today's guest, Dr. Sue Chang. Dr. Chang is an assistant clinical professor and chief of the Division of Anatomic Pathology in the Department of Pathology at City of Hope here in Duarte, California. She graduated from Harvard University and went on to receive her medical doctorate from the New York Medical College. And she later completed her pathology residency at UCLA Health. She furthered her training at UCLA Health and as a surgical pathology fellowship at Brigham and Women's Hospital in Boston. She's been published in many peer-reviewed literature and has presented her work nationally. And all that is to say that she really knows her stuff, especially in regards to NET. Dr. Chang has joined us for in-person meetings when we used to do those at City of Hope, and also for our first COVID webinar back in 2020 when the pandemic first hit. So for more information about pathology and for videos and slides, you can go on our YouTube channel. So Dr. Chang, we're really excited to have you. And before we get into the 10 questions for today, could you just kind of tell us a little bit, well, I guess kind of basic terms, what is pathology and what made you interested in pathology?
Sure. Thanks for having me on this show, Lisa. It's really nice to chat with you again. I forgot that we were the first webinar during COVID. I remember like the scramble to figure out the AV stuff, right? And now
it's crazy.
Now you and I are like AV experts. Not really, but I was like, remember when I was like, how do I log on to Zoom? and now I'm like running 3 Zooms at one time. It's pretty remarkable. So it's really nice to see you and chat with you again. So you mentioned that I went to medical school in New York and I ended up doing residency at UCLA. What I didn't mention, and it doesn't fit in a little webpage bio, is that for a long time, I thought I was going to become a surgeon for a really long time because I like spatial reasoning. Surgery certainly is interesting. It's extremely gratifying in that you get to meet your patient, you get to do a thing, and then that really individually helps the person.
Yeah.
But when I was in med school, I kept disappearing to go to the frozen section room in the pathology lab. And because I would follow the specimen and I would follow it to the answers, right? And so it was always really gratifying, not just to have seen how it happened, but also to get the answer. What is this tumor? Is it involving certain organ systems, right? Is there lymph node involvement? So after a while, I was like, and it takes a long time to sort of like know yourself. And at the time I was like early 20s, but after a while I was like very slowly, oh, maybe it's pathology. And I think sometimes what happens is you don't see a lot of pathologists in TV shows, right? Or every once in a while on Grey's Anatomy, I think they show a pathologist, but it's almost universally unflattering or strange. It's not as sort of like name and lights type of thing. So it's fairly behind the scenes. It's extremely gratifying, but in a different way. So one of the ways I like to explain sort of the pace and like nuance of pathology is like football versus golf. So football, like make tons of movies about it, tons of TV shows. It's very splashy. And to me, that's a little bit like surgery, right? Like everyone knows, like they can name someone who's a surgeon or like their best friend's parent was a surgeon or something like that. And they make TV shows about it. And pathology is like golf. When you're watching someone play golf, it's so boring because you're watching them and they're like squinting in the distance and thinking really hard, right? And you're like, this is so boring to me. But then when people play golf, they're like, this is the most interesting sport. This is the most like mentally challenging and satisfying thing. And so if you're in it, you get it. And if you're not in it, you don't get it at all. And I think that's how I think about pathology. And so not everyone can name golfers, right? There's a couple of golfers out there, but most people don't. And that is how I feel about the sort of the PR issue, I guess, of pathology. But it is very cerebral. It's immensely satisfying, It's very intellectually stimulating, and you don't really hear about it too much. So I am on a one-person mission, I guess. There's a few of us actually, to sort of let people know how important it is. And there's an often cited statistic. It's from a few years ago that something like 75% of medical decision making is actually performed based on data from laboratory testing and pathology reports.
So true. Wow. Especially in NET. We know that.
Especially in NET, yes. The classification and sort of the terminology that's used really drives clinical management. It drives prognosis. It drives the conversations that you and your doctor have. Yeah. And so I take that responsibility really seriously. And all the pathologists I know take that responsibility really seriously. We are the most conscientious people that I know. And that's among doctors, which is a pretty conscientious group as a whole.
Wow. Well, we're really grateful for that because, as we just mentioned, it really does drive many of the treatment decision making for NET. So, most patients, their only awareness of pathology and the field of pathology might be that they get a pathology report. And you even take a step further, they know that they get reports in general. So people get lab reports, they get radiology reports, and they get pathology reports. And it's all a mystery because it's all in that field of reports where they don't see a person. So what is pathology and how do they kind of distinguish it from radiology and other reports?
So there are two ways you actually probably interact with the pathology department. The first, I think, is the most, I can't think of a single person who hasn't had a lab test, right? So your complete blood count, your fasting glucose, your hemoglobin A1C. Even if you do a urinalysis, a lot of those usually are done by the laboratory. And so those reports come out, they look, like a very line item, test result sort of report. And those tend to be more common, easy to understand. They give you a range even. Sometimes if you're out of the range, they put a little asterisk or it turns red. And so that whole thing is, by the way, a lot of development about trying to make things as readable as possible. Because it certainly doesn't come out of the machine that way, right? It doesn't come out with a nice little bar graph with a little asterisk if you're out of range or a little red exclamation point. But that is all like long-term work between laboratorians and scientists and patient people who are trying to make these lab tests more readable and understandable. A pathology report is also coming from the same sort of section of the hospital, but looks very different. There's a lot of words. If you look at it, the number one thing I always say is when you get your report, look in the top upper right hand or upper left hand corner, make sure it's your name. You would be surprised how many people like read the middle, the final diagnosis, and just like start to spiral. And then you go, oh, that's not my report. It's a little less common now that we all have electronic medical records and you have your access on your phone, but you have to log in. But in the past, like if you're all printing everything on the same office printer, if your clinic has the same one office printer, someone might pick up the wrong report, not double check and hand it to you. So that's just number one. We always do that. I mean, I do that all the time with my slides. I always am looking at a name, making sure it's the right one before I send it out. Because it's an easy way to make sure that no one unnecessarily goes through sort of an emotional trauma. And then the next thing is that you might notice that usually there's a section called final diagnosis or diagnosis. And that is the marquee top line, most important thing I want everyone to see. And when I'm writing a report, I am writing it for three groups or three audiences, right? The first always is for the patient. So it's on me to try to explain in as clear and as few or as many words as needed what the final diagnosis is. And I would say 75 to 80% of the time, it's clear cut. So there's few words, I know exactly what's going on, and we write it down exactly the way certain governing agencies like the World Health Organization or the FDA, there are certain things that we have to say in order to count as like belonging to this diagnosis. And so I would say 80% of the time, it's fairly cut and dry. And then I might give you some details that I think are important. More likely than not, if I put in some details in the top sort of marquee, it's also for your oncologist, your surgeon, the radiologist in some respects, to know, hey, I saw this, I called it this, I categorized it such way. Here are some pertinent details that you will find important, whether it means that it changes your thought about chemo, or it changes your thought about follow-up, or it motivates you in a certain way to do a certain type of surgery or not do a certain type of surgery. Here's information I think would be important for you, my colleagues in surgery, in oncology, in radiation oncology. Here are things I think you will want to know. And then the third audience is for other pathologists. So very frequently, the way that large institutions such as City of Hope work, we have a huge coterie of pathologists. So just because I see your biopsy doesn't mean I necessarily get to see your resection. Or if you come back in 4 or 5 years with a repeat biopsy, I may or may not be the person who receives that biopsy. So when I write this, I'm writing for the future pathologist, the next pathologist, or I'm writing it for if you're going to go get a second opinion somewhere else, and that pathologist at that institution talks to that surgeon, I want them to know what I saw so that they can confirm. I think of it as like a handoff, like a baton in a relay race, right? So here's all the stuff that I think you need to know. And then you can go ahead and continue the race. So in terms of when I write a report, I'm thinking about 3 different audiences, which might be why sometimes these reports seem so esoteric. I know there are words in there that patients don't understand. And there are times when I would say I wouldn't stress too much about like the second or third or fourth page, because a lot of those times those words are not, those are details and they are not like the marquee things I need you to read. Everything I need you to read is under the final diagnosis. And there might be a comment if I like decide to get literary and like want to write something or sort of call attention to something. But those are the top 2. If that's all, and I really understand that because I've been a patient myself, right? Like when I get a report, my brain shuts off. Like I'm so panicked sometimes. And I've seen my parents even, right? Like looking at like a biopsy and they, like, you can't see the words because you're like so spiraling already too far in your own head. I get it. So if that's what happens and all you can do is get the first page, that's fine. That's all you really need. All those other pages, you can shove it at your surgeon, at your oncologist and be like, have you read all of this? And they probably have, because I get phone calls from my colleagues being like, on page 7, you said, what does that mean? And I'm always like barely gratified that someone is reading for detail, because that's why I put it all down there.
That's amazing. It's so reassuring to know that you're communicating with 3 different audiences and not all for the patient, that you're giving permission to not have to understand every little detail of it.
You don't have to. And if you hand it to someone who's helping you through this and they're able to comb through it, just highlight some questions, you don't have to read it. Somebody has to read it, right? Somebody has to read it. And it can be really esoteric. And just know that like, you're not going to get quizzed on it. Like, I'm not going to ask you like reading comprehension, right? So really it's for you to have in your hand to take around and make sure other people get the baton and get it correctly. That's the power of the report. Because one of the other things about most cancer centers is that people who work in nets, people who work in this group tend to talk to each other all the time, right? So our surgeons, our oncologists, like we meet maybe every week. I get phone calls all the time. So we're constantly in communication. But that communication is in the form of emails, it's in the form of secure messages, but it doesn't go with you if you're going to go to another institution. So it's really important to me that that document that you have, which is the pathology report, that captures everything. I might tell your surgeon over at USC, right? That I might, if I had the chance to talk to your surgeon over at MD Anderson, what I would say. And we don't always get to do that. And so what I have instead is this paper enduring material that you can bring to them and they can see it and go, oh, I know what she's trying to tell me. Even though I've never met your surgeon over there, I've never met your oncologist that you're going to see somewhere else.
Yeah. And that baton becomes a really important piece. And so from the patient standpoint, for a net pathology report, what should I, as a patient or caregiver, pay attention to in the report? I know you kind of mentioned the final diagnosis, but what are the important pieces?
Right. The first thing I would see is if you had a biopsy or a surgery, we always write the location. So if maybe you had a core biopsy of your liver, it should say something like liver, biopsy, core biopsy of liver, something like that. Make sure that the place that you were told you were getting biopsied is the thing that I got to look at. If you had an appendix resection, right, make sure that it says appendix, and then any other parts that maybe was part of your surgery. The second thing I would want you to read is that final diagnosis, marquee diagnosis. Basically, what pathology does, this is very general, is that we group like with like. Some days I feel like that's all my job is. It's just like putting things together and corralling all of them and saying, okay, you guys are a team. You guys are one group because you all kind of look the same. You all kind of do the same thing. You all kind of behave the same way. And so we're going to group you all together and run a bunch of data on you to try to understand what happens when people of this type of grouping have this type of tumor. So I would look for that. And there are the WHO, the World Health Organization, publishes essentially categories. Sometimes I think of them as like menu options, right? And so you try your best to sort of understand which one it should be in. Sometimes they don't. People, always being people, defy categorization. And those are the times when you like really have to put on your thinking cap, sort of problem solve, and like either do a best fit or make a suggestion, but sort of keep the dialogue open. So the thing that you probably would find the most useful, especially for carrying that baton, is what category is this in? And you will see words, especially in the NET field, you'll see words like well differentiated and poorly differentiated. You'll see grade 1, grade 2, grade 3. You'll see large cell, small cell. So those are the words that you will commonly see. And what will happen is that the combination of those words puts this tumor in a particular category. And that's really important for prognosis because every person is different, but we try to make generalizations so that we can give some sort of signaling and try to understand what particular tumors do. And then the other thing is that treatment is also dependent on the way we categorize things. So I don't mean to make it sound like pathologists are like the most important people, but I do sometimes think pathologists are really important because if I'm categorizing it with incomplete information, that could have repercussions. And I take it really seriously that I'm categorizing it in the best way possible with the information, all the information I have in that moment, so that my colleagues can say, okay, this is the type of surgery we're going to do. Okay, you can come back in 6 months and we'll look at it this time. And the other thing I really want to stress is that each biopsy or surgery is a moment in time. So we do our best work each time. And that often means that as we get information, as we get more information, as we get better imaging, either because we get more information because it's been years and years and now we just know more about you and your case, or we get better technology, right? The imaging has come so far. The different ways that we can image have come really far. So now we know way more than we did 5-10 years ago. It also means that sometimes we have to do kind of a radical recategorization, like a reassessment of our own rubric. And so I think people can get really upset when changes happen, like, oh, were you wrong in the past? No, everyone is just learning. And sometimes it takes a lot of courage to say, you know what, we have to change the way we grade, change the way we stage. And ultimately going forward, we now know more than we did before. So I think in 2017, a slightly updated classification of NET tumors came out. There was a lot of angst. I mean, it was actually probably ready to go about a year before it came out. But I think what it was managing the anxiety of the pathologists, of the surgeons and of the oncologists, to say nothing of the wider audience, right? Like we knew this was going to happen. And so I think one thing I would say is if you have an older report, think about it in that way. That is the categorization, and that's the information we knew at that time. So if you're looking at a report that you've got from 2004, it may look pretty different from the report that you got last week.
That's helpful. Yeah, thanks for giving us the bigger picture historical context. So, kind of taking a step back, this is really important, we know, to get to the report, but even getting to the process of the report, we get a piece of tissue from a biopsy or from surgery, and it comes to you, to pathology. What type of staining should be done for NET tumors? What do you do?
If we were in person, I would show, I had that whole PowerPoint. My lab staff love when I take pictures. I mean, they don't love when I take pictures of them, but they love when I tell them who I'm showing it to. I wish you could see in our lab, there's 46 people.
Wow.
Just for a biopsy. I mean, they don't all do the same thing. I mean, they don't all do the same thing. They all don't all do different things, but essentially it takes 46 people to process all this biopsy work so that we can sort of get you the best diagnosis. You may see sort of buried in the, I call it the fine print. Again, if you want to go and read the fine print, more power to you. I love a detail, so I get it. But if you never read this, don't worry. The routine stain that pathologists use is shortened to H&E. That stands for hematoxylin and eosin. And they are very old stains. They're very pretty. They're purpley blue and like a hot pink. Pathology is very colorful. Radiologists are very jealous because pathology is so colorful and beautiful. But it's like this like neon pink, shades of pink and red, and then like a dark purpley blue. So those are the ways that we stain the slides as a routine so that we can tell what's a nucleus, what a cell looks like, what blood looks like. It's very interesting to sort of differentiate between them. Our human cells are not, unfortunately, hot pink and bright purple. That would be so great, but they're not. They're pretty clear. And then on top of that, you might see other reports of things. And these are more specific to NETs. These are more specific to NETs because they tend to, again, talking about grouping, right? So breast cancer looks different from NET. NET looks different from leukemia. They look different and they do different things and they have different, what we call antigens on their cells. So you might see something like synaptophysin, chromogranin. A slightly newer one is called INSM1. And those are basically ways that a cell tells us, hi, I'm of neuroendocrine differentiation. I express neuroendocrine features. You don't always have to do them. I think some of the more cut and dry cases, or if you've done one more recently and you know what's happening, you don't have to. It is very helpful. Certainly for a first-time diagnosis, it's recommended. I'm trying not to like say anything that'll get anyone in trouble. The practice of pathology is fairly broad. Pathologists are all very well trained, so I wouldn't worry too much. Like I wouldn't call them like must-do checklists, right? Like it's not like you have to put on your seatbelt. Like it's suggested, it depends on what you've got going on, but those are ones that you may or may not see. And then I think the one that everyone wants to talk about is the Ki-67, which is a proliferation index. So a Ki-67, it's an acronym, and it basically looks for cells that are in a particular stage of DNA replication. And when you have labeling of these cells, you can count them and you can basically get a rough estimate or a reckoning of how rapidly a tumor is growing. So it's not dissimilar to how radiologists over time will see how much a tumor grows. And you'll see they measure it constantly, and you'll see like was previously 1.4 centimeters is now 1.9 centimeters. This is what they're doing. Or like a PET scan, which basically looks at metabolic activity. So this is a similar idea, different details, but similar idea that basically tries to understand how rapidly a tumor is growing. Mm-hmm. And not all NETs, but most NETs use the Ki-67 as one of the criteria to figure out grading. It's not the only. I think we talk about the most because people love numbers, and numbers are easier to break down.
Yeah, that's helpful. So typically we would be able to find it on the pathology report.
Yes, it would be probably in the fine print. Again, because what I do is I look at all of the details, I figure all this out, and then the conclusion is what I put at the very top. Mm-hmm. So it's like arithmetic, right? Like I did all my work, and then I circled the answer, and then I wrote the answer in the little answer slot. But if you really wanted to, you could look at all the chicken scratch and all the work that went behind it. And some people like to, and some people don't, but we definitely put it all out there so that you can see it.
Yeah, well, thanks. I mean, to kind of simplify all that work that you do over, it sounds like quite some time, to 1 or 2 lines.
Yes, exactly. And that's the most important thing though, right? If you look at that and you walk away and say, okay, I know it's a well differentiated grade 2, that's all I really wanted you to take from this if that's all you wanted to do today. But if, I don't know, you're waiting at the DMV and you're like, I really wanted to know what my KI was, like, go ahead and flip to page 4, take a look at all the work that I show and like how I do it. And if I did a mitotic count or not, which I think might be another thing that you might be looking for. A mitotic index is a count of how many cells that we see that are in the middle of dividing. So mitosis is the method or the description of the stages of how DNA replicates. And when you see a cell that is undergoing mitosis, that means that that cell is dividing, right? And the mitotic index is another factor in determining the grade of a tumor. And there are different ways to do it. Thank goodness. Some people are coming up with AI, artificial intelligence ways for computers to do it. Because I had to tell you, it can be pretty mind-numbing to sit there and count mitoses for a while. You just feel like it's Where's Waldo sometimes, like you're just like looking and looking and looking. And so now there are a lot of technologies out there that help us to do a more reliable Ki-67 or mitotic index. So it's pretty exciting. Not every place does it. It's pretty high resource to set it up, but a lot of places are starting, and it's really exciting because I think what will happen is that people even across different days can have like some variation of how they do things. People across other people, so me and my next door neighbor may not do everything exactly the same. And so you spend a lot of time, we do this all the time in pathology conferences, we spend a lot of time like checking that we're on the same page, checking that we like kind of do things the same way. But what always does the same thing the same way is a computer. So that might be something in the future, hopefully, that becomes much more easily and reliably consistent. We're pretty good, but people being people, you can't always 100% be replicating the same thing. So that's more than you wanted to know about the mitotic index, but I have a lot of conversations with other pathologists about AI. It's the big promise of the future. I think it can only help us in terms of getting consistency across the board. And I think a lot of times what ends up happening is the more pathology I do, the more I see variability in how people present and how pathologists think about things. And at the end of the day, we're all striving to do the same thing, which is to have a consistent and replicable, right? So that we can really take population data and understand what happens. So each person's story is really important. Don't get me wrong. Like I really believe that. But at the end of the day, and I hear this a lot from patients, like what people want is for their suffering and their trials and their tribulations to mean something. And I think that all starts with data. That all starts with getting a reliable way to sort of group people together and then have long-term population studies so that we know what all of this means. That's all I'm trying to do.
Yeah. Well, that's helpful, right? Because we want to make sure that this data is solid. And so all that to say that with all your work with mitotic index and Ki-67, it's all to get that bottom line to define what the differentiation and grade is.
Yes. And they don't always agree. I don't know if you know, but tumors, they don't like to read the textbook. Like they don't like to follow rules. So sometimes not often, but sometimes the Ki-67 will seem higher than the mitotic index or vice versa. And at that point, it's a phone call, right? At that point, I call my colleagues and I go, okay, this is what I see. Help me figure out which we want to go with, right? Because at some point you have to make a decision and which one do you believe more? And sometimes the answer is we should get another biopsy. We should do some more stains. I should look at another part of the tumor and see if that tells me more. So a lot of these lead to conversations, which I think is the most important part.
Yeah, collaboration and getting more data. So I'm curious, this kind of leads into the next question. How does a tumor location play a role for what testing a pathologist or what you might do?
As we know, NETs really can show up all over the body. They can show up in different ways. Occasionally what happens is they show up first in the liver, or they are most prominent in the liver. And at that point, primary neuroendocrine tumors of the liver are exceedingly rare. Much more likely is that there is some other primary that we have not seen yet or is very small, and we have to figure out where it came from. So a liver biopsy, for example, always sets off a search for a primary. A pancreas biopsy or a pancreatic lesion, you have to think hard because most of the time it can be a pancreas primary, but sometimes on rare occasions it's actually coming from somewhere else. And so the location means that you have to do a little more detective work depending on where it is. And the other thing is that the behavior is different. So it's well known that in the lung, there's a higher acceptable level of Ki-67 or mitotic index to still be considered a grade 2. And I don't think anyone is sure about why. If it's because the lung as a location is special, if it's because of the physiologic sort of in and out of air, like who knows? I don't actually have a good answer for that. But it is known that a lung net is different from a pancreas net. And that's different from a rectal net.
Yeah. Okay. So it's really important when you get your specimens to know where it came from. Yeah.
Yes.
So I know we've been talking around these terms, so let's kind of break it down a little bit. So what specifically is tumor grade and why is it important? And how do you determine that? And how, I know that on the patient end, there's all these terms. So how's grade different from stage? I know I threw a lot of questions out there.
Grade and stage are cousins. They help us figure out what's going on with the family, but they're not exactly living in the same house, I guess. I don't know. This metaphor went crazy. But grade and stage are cousins. They look alike, but they do different things. Grading is what the tumor looks like. Grading is about the tumor itself. So in NETs, grading is about, like I had mentioned, the synaptophysin and chromogranin, so sort of like what it looks like and what it's expressing and what antigens are on its cell, how it decorates itself, essentially. And also about mitotic index and Ki-67, so how quickly it's replicating. Those are the things that help me figure out grade. Stage is about what the tumor is doing externally. So the stage is comprised of 3 things. The first is what we call the T stage, so your tumor stage. Typically, it's about the size and the extent of involvement. So if there are certain size cutoffs, and again, all this data is because we've had decades and decades of retrospective look back, right? And so you sort of put all the data together and then sort of draw somewhat arbitrary lines in the sand and say, when people have a tumor that's 2 cm or smaller, it looks like this. When you have a tumor that doesn't involve this organ, they do these things. So the tumor stage is typically it's about the size of the tumor and or what it involves, what portions of the GI tract it involves, or a size differential. And then the N stage, it stands for nodes or lymph nodes. And that is this tumor anywhere else other than the original place? Is it in any lymph nodes? And again, you can have different N stages. And then the last is M stage or metastasis, right? And so we had talked a little bit about liver. And so if it's gone to other organs, that changes your stage. And those 3 things, the T, the N, and the M, get put on this big table. And depending on which of these 3 they are, you end up with one overarching stage. So much of medicine is taking bits of information, individual data points, and then generating an overarching category based on these parameters. So your stage is often done sort of in a collaborative way. So for example, if I'm looking at a biopsy from the lung, I don't know the end stage. I don't know the metastatic stage, but the imaging will. The imaging will pick up other things. So it'll be the proposed clinical stage for a person might be a combination of things that I say and things that the radiologist says, and maybe things that they find on physical exam. It's a group project, essentially. Mm-hmm. The grading, though, is essentially done by pathologists. That one is me with a microscope and some stains, trying to figure out which one it's best graded as.
Mm-hmm. Okay, and I know we already talked about Ki-67 and mitotic index and what they are. So I guess bottom line, what would you say how important is this for the tumor grade?
The Ki-67?
Yeah.
So the interesting and terrible and irritating thing about working in a field that goes all over the body is that everyone's been working on it separately for a really long time. So there's not one single unified grading schema, which leads to some interesting conversations. So for example, the reason I'm saying this is, for example, in the lung, the Ki-67 is actually not part of the criteria. It's suggested, and I think most people do it because you may as well. Everyone wants to know more data, right? I want to have all the possible help I can get before I make a grouping. But technically speaking, you don't need to use it. And so if you don't see one, it's not actually like someone's not done a good job. It's just that it may not be part of the need. And also sometimes it's not necessary in terms of like, there's so much data that you've got from all your other stains and all your other microscopic examination that you've made a categorization. I would say it's probably less common, but I wouldn't freak out if there wasn't a Ki-67. But for all the other ones, a Ki-67 is one of the data points you actually need, and it's required in resection. So your big resections, it's a required data field there.
Okay. So we talked about Ki-67, mitotic index. What is differentiation and how do you decide this?
Differentiation is a feeling. And I'm sorry to say that because I sound so unscientific, but the further I get in medicine, the more I realize so many things are a feeling, or I guess a judgment or a determination that isn't black and white. So differentiation is essentially saying how well this tumor cell resembles its normal counterpart. So how far afield it's gone, right? Because some tumors like really forgot where they came from. They do not look anything like they used to, or they should. And so in the NET world, there is well and poorly differentiated. There is no moderately differentiated in the NET world. In other organ systems, breast, colon, adenocarcinomas, those are moderately differentiated is an option, I guess. But in NETs, it's fairly binary. So you have your well differentiated and you have your poorly differentiated. And those two really tend to track fairly consistently with clinical progression and survival and stage, actually. So again, they're all cousins, but they're not necessarily all living in the same household. But they do sort of all kind of go together. So your poorly differentiated NECs, neuroendocrine carcinomas, tend to have high Ki-67. They tend to have high mitotic index. And your well differentiated tend to have low mitotic index, low Ki-67, because they're not replicating as quickly. And they tend to look, to my visual eye, more like the normal counterpart of neuroendocrine cells. Your neuroendocrine cells are all over your body all the time. They're regulating things, they're hanging out sort of in the background, doing their thing quietly, and they look a certain way. And your well-differentiated NETs, neuroendocrine tumors, can look like those guys, just too many and in a weird place. So that's basically how I think about differentiation. One day we should come up with a visual podcast. That's just called a lecture, a webinar. If we were doing a webinar, I would put a bunch of photos up. And I think it's actually pretty obvious, to everybody when you see it. Like one of these looks very different from the other. So if I put up a picture of a normal neuroendocrine cell, a well-differentiated neuroendocrine tumor, and a poorly differentiated neuroendocrine carcinoma, you can tell like one of these does not look like the other. So that's how I explain it. There's a lot of exciting development in terms of the molecular background of these. There are groups that say that if you sequence everything, you can tell the difference based on the mutations and the driving molecular changes between well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. That's really exciting because it means that there's a genetic reason for the things that we're seeing. And it also means, again, I'm gonna say, I really want as much help and information as I can get. If that means that somewhere in the future, all neuroendocrine tumors get sequenced, same as a Ki-67, it just becomes routine, that's really exciting in terms of it really helps us understand what's driving certain behaviors, what mutations might be sensitive to certain drugs. You don't know. There's so many things that have changed in the field of medicine, even since I went to med school, that I think it's really exciting to be able to continue to understand what's going on.
Yeah, always want more data. That will help as well. So a couple other terms that come up sometimes. What are atypical and typical? What do those terms mean?
Those pulmonary guys, those pulmonary guys sure love their own vocabulary. So again, as I said, there is no single one like ruling entity that decides what is called what. So in the lung, which is also called the pulmonary system, you will see slightly different terms that for the most part sort of similarly track with the GI nets. So typical carcinoid basically, not exactly, but basically tracks with a grade 1 well-differentiated neuroendocrine tumor. And atypical carcinoid typically, generally, mostly has the same characteristics as a grade 2 well-differentiated neuroendocrine tumor. So not exactly the same. Again, the mitotic count is slightly different, and the Ki-67 can be slightly different. But the pulmonary pathologists I have actually seen now will do both. They'll give you what they call typical or atypical, and then in parentheses, they'll write the other category, because again, we're all just trying to like make sure we're all saying the same thing or speaking the same language. So I've seen that come up more frequently recently, which is really helpful. So hopefully if your listeners are seeing this, they'll see them side by side. So it's just sort of like older terminology with newer terminology, and then hopefully the two sort of at some point like merge together and we can just use one vocabulary.
Yeah. So speaking of just trying to kind of make sense of things, can there be different grades within the same tumor or between multiple tumors?
Oh, definitely. So again, pathology is so strange because we're taking a 3D person, we're taking a little part out of a 3D person, and we're converting it into a 2D image. So I'll never be able to see in 2D the full-fledged 3D person or 3D tumor or what's going on in a three-dimensional way, which is why we sample. We call it sampling, right? So wait, I look a little bit here, I look a bit over there, I look all over the tumor. And just like, maybe not all of your hair grows in the same rate, right? Maybe the front of your hair grows slower than the back of your head. You have to look at the whole picture together. So it's entirely possible, especially in someone who's had prior therapy and then they go to surgery, or if they've had radiation in a certain portion of their body, that the Ki-67 or mitotic index looks different. And what we end up doing is basically looking at the highest mitotic rate and using that, because that's really the area you want to know about, right? And what we'll often do is, if there's a case that comes across my desk that's got a primary resection and a bunch of lymph nodes and a lymph node met, I'll look at all three of them and see which one's got the most aggressive behavior. It's not always the same. So sometimes you say, oh, it'll be in the liver, and it's not. It's actually in the lymph node. Or sometimes you'll think, oh, it must be in the lymph node, and it's actually in the primary site in the small bowel. So it really depends. And at the end of the day, what we end up talking about is whatever is the most aggressive. That's the part that we're the most concerned about. And that tends to be how I grade things, depending on whatever is the most aggressive.
Yeah, that's helpful. Going with the, knowing that that's the most important piece that you're
Right.
looking for, the most aggressive. So what about pathology reports? Throwing another curveball. How do I understand a pathology report that shows mixed neuroendocrine neoplasms?
The tumors don't like to read the textbook. They really like to throw you a bunch of curveballs. And one entity that is it's still in flux, actually. There's a lot of research being done, is sometimes your tumor will look like two tumors. And there'll be cells right next to each other, like cozied up, that look totally different from each other. And you're like, I don't understand how they can both be tumor. So there are a few different schools of thought. One school of thought is that it is actually two tumors that both got the same sort of genetic hit and just like took off and became malignant. There is another school of thought that says, no, it's a tumor that has portions of it have changed into a different look. So like I said, in the past, chromogranin and synaptophysin are what we call expression, right? So it's what the outside of the cell looks like. It's what's producing. And some cells have decided we're not going to do that anymore. We're going to make a different thing. We're going to look in a different way. We're still going to look bad, but we're going to look bad in a different bad way. And so that's actually a really complicated field and deserves a lot of, I think it deserves a lot of attention and funding, because it can be called a mixed adeno neuroendocrine or a mixed neuroendocrine, non-neuroendocrine neoplasm or carcinoma. And anytime you do a mixed bag, you get mixed bag results, right? You get mixed bag prognoses. So it can be really difficult to prognosticate because you're not able to say with as much data or power behind it, which was going to be the bad actor. And frankly, sometimes we're surprised by which one ends up being the bad actor. It seems to be about 50-50. I know that a lot of times people say it's the adenocarcinoma that acts more poorly. I think if you're working at a cancer center, you reserve the right to see it go the other way. And so those are mixed bag, and they're mixed knowledge too. And I think that is one field that has recently and will continue, I think, to get refined, and as we get to know more about what the molecular drivers are. So I guess watch this space in terms of what we're going to do with it. It's really frustrating, though. I do totally understand. It's frustrating to diagnose. It's frustrating, I'm sure, to treat. And I'm sure it's extremely scary and frustrating to be a patient with this diagnosis, because it's a zebra within a zebra.
Like a unicorn.
It is. It's a unicorn.
Mm-hmm. Lots of muddy waters and the need for clarity in this space.
Yes.
Okay. Well, last question is really, should I get a second opinion, or better yet, when should I get a second opinion with my pathology? And if so, how's that done? And also, how long are pathology specimens typically stored?
These are great questions. I love talking about this. It's not just nets, right? So this is something I'm going to say across the board for all pathology. So this will be helpful I hope this will be helpful for anyone who's listening in terms of how the field of pathology, how the practice of pathology goes. Should I get a second opinion with my pathology? You know what? I have seen a lot of pathologists' work come across my table, right? As a person who works as a reference cancer center. And by and large, I am so impressed with pathologists. Like, truly, our board process is extremely rigorous. The people who practice pathology that I've had encountered with are similarly conscientious. They keep up, they teach me things. So I am, by and large, incredibly impressed and confident in pathologists as a general group. I am never offended if someone asks if they can send their pathology for a second opinion. And that's why I write my reports the way I do. I assume they're going to go get somewhere else seen. And I want the other guy to know, like, here's all the stuff that I did. And I think that's how we think about each other, because when I receive an outside report and I'm looking at it, I'm always like, yep, great. Sounds good. I agree with you. So it's really gratifying, I think, to get that confirmation. And here's the other thing. If I missed something, I want to know, right? I want you to know. And I want someone to say, hey, there's an extra piece of information out there that could be useful. So I don't get offended ever. And I think people are like, are you hurt, or are you? No, I'm not. You know, you're trying to get good care for yourself. And that's what I'm interested in as well. I will say that at City of Hope, and not at all places, it should be at all places, but not at all places, but definitely at City of Hope. If you come to see our oncologist, if you come to see Gog Singh for surgery, he will be sure to get your pathology reviewed here, because we're going to talk about you at your report. And it's really important that he and I have a conversation about what his plan is. So he's planning a surgery based on other people's words. And I would say 98% of the time, I would use the exact same words. But that 2% can be really important. That 2% might mean something. And certainly for Gogs to go in with the confidence that he's doing the right thing, that's irreplaceable. Even if it is just me saying, I agree with this person, then he's got that confidence boost to say, I know this is the plan we need to do, as opposed to, you know, I'm pretty sure, or I'm sure, I hope. And if that's what it takes, then that's what it takes. I'll never mind looking at another report so that my oncologist can make the best plan and have confidence in it, or that my surgeons can make their best surgical plan and have confidence in it. So we often send out tissue because a patient has decided that they are going to another institution for their surgery, or maybe, you're moving to Florida. You've retired, you're moving to Florida, congratulations. You want to set up your care down there in Florida, then ideally what would happen is that your new place, that's your medical home, will get to review all this stuff. And they'll say like, okay, we've got the baton and we're going to carry it forward. How it's done, it's generally done by your treating oncologist or surgeon or radiation oncologist. So they basically say like, I'd like to make sure that these all things are reviewed. And it's part of, I guess, like a startup package, right? Like your new patient, here are all the things that have to get checked out. All your medications have to get re-reviewed. We ask you again, your surgical history, your family history, we get your pathology reviewed. I think it should be part of that sort of onboarding of a person to their new medical home. That's generally how I've seen it done. And it's probably the most effective because the people who are working at these large hospitals or clinics, it's very standard. And so there's a lot of paperwork involved.
And just curious, do you look at the actual slides?
Yep.
The slides are sent over to you.
The slides are FedExed in little like protective carriers with a bunch of bubble wrap. Speaking of going digital, a lot of places are now going digital. So my great hope is that in the future, we can do this digitally with slides that are made into very large TIFF files, specialized TIFF files, because it means that you don't have to depend on shipping. And FedEx doesn't lose things very often, but if they did and it happened to be yours, like, could you imagine, And so there's always some anxiety about sending things out. And also it means that everyone's got a copy. And so you keep a copy and it's safe. Your second part of your question was how long we retain specimens. So if you're going for a surgery, you might get a big portion of your liver taken out. We're not going to put the whole thing through the machine. That's too much and most times not necessary. So what ends up happening is that we take portions of that, we sample it, and we put the rest in a container with a fixation chemical called formaldehyde. That container sticks around for about a month after we've signed out the case, just in case we had to do more things for it. The actual tissue gets processed and embedded in paraffin wax. And once it's in there, the DNA is stable for decades, very long time. The RNA, there are other portions of it that are less stable. And generally we like to say within the past year is the most likely to be able to do molecular testing and additional testing. But the tissue itself is stable forever, as long as you are storing them in the appropriate climate controlled area. Sometimes it can be challenging in places like Los Angeles or Las Vegas because paraffin melts. So we're very conscientious about temperature. We actually have temperature monitors and they like alarm and go off if it gets above a certain threshold of temperature. So any laboratory has to get inspected about this. Our inspection is actually coming up. And so I'm very, very aware. But every laboratory that stores these items has to do temperature monitoring. And so that's one of the ways that we should make sure that your specimen is safe and can be used for additional testing in the years to come. There are certain laws about how long you must or can retain specimens. So it can vary depending on the hospital you're at or the clinic you've gone to, the state that you are at. There's a minimum federally, that's 10 years, but that's the minimum. But many places far exceed the minimum, just because certainly at City of Hope, we know that we have patients who come for decades, right? And we're lucky to have them for decades. And so we actually retain our specimens for as long as possible, just in case something comes up, right? And you're like, there's a new wonder drug and we want to test something from a long time ago. That's always our priority, is to make sure that if you're able to use it for that patient's use, for that patient's treatment or prognosis or therapy, that's my priority. We are also a research institute, so don't get me wrong. There's always interest in using what we call archival tissue, right? So older tissue to promote research. And I'm very aware of that. And I believe in that. But I really have to emphasize at the end of the day, my loyalty is to my patient. And so I will always think of that first before what we call secondary use or like additional research. So I hear a lot from people who are like, I really want to participate in research, but I'm concerned that it means that I won't be able to get further testing or do this thing. What if I need to go into clinical trial? And I want to assure people that I always think about you guys first. I always think about my patients first. And then if there's anything additional or duplicative, that's when I say, okay, research, you can come on in, but it's me and you, the patient, first and foremost at this tea party before anybody else gets to come in.
Patient-centered. We love that. Yeah. And so we can expect the pathology specimens to be at the institution or hospital where the surgery or biopsy was initially done.
Yes and no. So it turns out space is a premium. And so for some of our archival specimens, at least at City of Hope, it's after 3 years, we have them. It's offsite. Again, temperature controlled, highly regulated. It's not like anyone can just like walk off the street and go get it. If you think about it as like the library, right? So sometimes you have offsite storage of books and they're in temperature controlled places, and you can make a request and it takes a couple of more days, but they are in our possession, just offsite. So yeah, the answer is yes. Sometimes it takes a little bit longer because we do have offsite storage, but they are still tightly regulated and very secure.
I think of those like garage storage unit where we might store things outside of our house, but
exactly,
much better.
Much better, temperature regulated, and like I don't even think most of us have access. Even fewer people have access because it's like offsite. But sometimes I think about like how nicely they must. I mean, my own home isn't very well temperature regulated.
Well, thank you so much for your time. And just in closing, I just want to see if you have any final thoughts or any words of hope that you would like to share with the NET community.
I just think it's so rewarding to talk with you and Lindsay and the whole LACNETS team. And anytime I get to meet patients, it's like, especially for me, such a highlight. I think you know, if you're a surgeon or an oncologist, you have clinic and you get to see people all the time. So it's really gratifying for me to know that people are interested in their pathology report and in what I do and why it drives so much of the clinical decision making. And I wanted to thank you guys for holding this kind of space for both groups to be able to do it. I think it's just so important that we get to talk to each other.
Yes, of course. And we know that it's so important. I know that our audience, our patients, we really learn, you know, what those couple lines are that you put at the bottom of or at the top of the pathology report, differentiation grade. We really understand that that's highly valuable and very, you know, very instrumental in guiding treatment decisions. So we really appreciate all your hard work, all the attention to detail, all the hours you put in, and also all the research and the forward thinking that you're thinking about in terms of how to make it better. And thank you also for collaborating. That's really amazing to us, and it's reassuring to hear.
Yeah, I'm really lucky to have colleagues like Dr. Singh and Dr. Lee, Dr. Kessler to work with here. It's really fun, I guess, to do collaborative research with people who like get it and who have sometimes what I would consider wild ideas. I'm like, what about this? And I was like, this is so out of the box. But you know, this isn't out of the box, outside the box thinking type of tumor. And so you sometimes have to be a little bit creative and a little bit weird to sort of try to figure out a different angle to tackle the problem.
And we appreciate that out of box creative thinking because that leads to more options, and that's what we need.
Yes.
Well, thank you so much for joining us today. And we look forward to seeing you hopefully in person in the future.
Gosh, I hope so. Thank you. Thank you for having me. And I hope to be able to see you guys or, you know, have a conference again soon. I'm a very gestury person, so I feel like we're missing all the gestures. But next time we see each other in person, look out for all the gestures.
For sure. We look forward to it. Thank you. Thanks for listening to the LACNETS podcast. We want to thank our podcast supporters, Advanced Accelerator Applications, Tercera Therapeutics, and Ipsen Pharmaceutical. For more information about neuroendocrine cancer, go to www.lacnets.org.